science that isn't as well known as others. But the whole field really revolves around the concept that your brain can like look fine on like an MRI or a CT scan, but it could always function better. And those functional connections, they're called synapses, but those functional connections, they don't show up on brain scans, not on like MRIs or CT scans. And then really just trying to bridge the gap between, you know, what has historically been two fields. You know, we have psychology and we have neurology, but both of those fields look at the brain. Right? So brain health is going to be the big topic of what we're discussing today. And it's something I'm very passionate about. I come from a family that has neurological conditions, you know, with brain injuries, and psychological conditions and mental health issues. And just knowing that, you know, no one treatment protocol is going to work for all people. The brain is so unique. It's like our fingerprint. There's no two people with the same brain. So sometimes you really have to think outside of the box to find what works best for you or your family member when it comes to brain health, right? Be it neurological health or psychological health. So, you know, just kind of diving in to what we're going to be talking about. I think one of the big questions that we could have is, what is the function of the brain? You know, and looking at what those functions are allow us to better understand how to make the function better. So taking it just, you know, really stepping it down, you know, the brain is designed to interpret, well, really to perceive the environment and then interpret what it's perceiving and then respond to it, right? And then when you're looking at how that can really differ, you know, based on what you're perceiving. So say I'm perceiving a bear in front of me, you know, my interpretation might be danger, and then I have to respond by running away or playing dead. But if I were to perceive a bear, but it was maybe behind a cage, or I'm perceiving a bear, but I know that I'm, you know, in my car and the whole thought of today is to view bears, that maybe my interpretation might be, oh, cool. And then my response would be, let's take a picture or something like that. So really looking at what the function of the brain is. So let's look at someone that I think does know a lot and had a really remarkable brain. So that is Dr. Stephen Hawking. So he said that he regards the brain as a computer, which will stop working when its components fail. So looking at how computers work, we can kind of say that the brain, like the tissue, is the hardware, and then all the thoughts, all the connections, all the functions is the software. So let's dive into what brain health is. Brain health is psychological health, right? We have emotions and processing and feelings and behavior, but we also know that brain health is social health. Our relationships, how we interact with others, the empathy, the sense of community that we either have or don't have, that can affect our brain as part of our brain health. And then of course, we also know that brain health is neurological health. We have the autonomics, which is all the things that happen automatically for us in our body, like breathing and heart rate and sweating and when we digest food. So we'll talk a lot about autonomics here in a little bit. And we have all our reflexes, right? And some of these reflexes help keep us alive, help keep us standing. We have movement, and then we have cognition. So neurological health is multifaceted, just like psychological health or sociological health as well. But they're all a part of the same organ, right? They all represent brain health. So one model of care that I am a huge proponent of is the biopsychosocial model of care. We need psychological health, we need biological health, which is in this instance, the neurological health, and we need good social health to be healthy. So all of these interact with each other. They're really kind of like a three-parted triangle, if you will. And if any one part fails, the other parts suffer too. So say, you know, for an example, I got the chicken pox, right, as a kid. Maybe my social health is affected because I'm not able to go on a field trip with my classmates, and I'm missing that sense of community, or my friendships are suffering because of it. And then psychologically, I can be saddened by what's occurring, and the pain of having these itchy bites all over, or itchy, chicken pox, and actually make me be more irritable because pain can actually change the way our emotions are presenting. Think of it, you know, a bit of a different way too. You can have something psychological, like say anxiety. Like even before I started this call, thankfully I had Erin to chat with me for 5 or 10 minutes to get my nerves down. But before I speak, sometimes my stomach hurts. I'm actually sipping ginger tea here. Sometimes my hands shake, or sometimes I can sweat a little bit, right? When you get anxious, the phenomenons that occur can be biological, right? They can be something that is physically happening to your body that's caused by something psychological, and that can definitely affect your social health too. What if I got so nervous I had to cancel, and then I'm not being able to be a part of your community today? So just a couple examples of how psychological, biological, and social health all play together in a model of care that helps represent real full health. So one way that we look at this at Plasticity Centers is we have a plasticity pyramid of neurorehabilitation. And the thought with this pyramid is that we have to have some really basic foundational functions to build upon to create really what the pinnacle of being human is, which is behavior and cognition. So at the base of the pyramid, we have autonomics. And the reason we say this is the most foundational level is because it controls blood flow. Our autonomics is in charge of that rest and digest state, which is called being parasympathetic. And when you're in that state, you get good blood flow to your brain, you get good blood flow to your guts, to allow for good rest and digestion. But we also know that the other half of the autonomic nervous system is being sympathetic. And sympathetic nervous system is what controls the fight or flight. So when you're in that fight or flight mode, you actually shunt blood, or kind of the brain tells blood to flow more in your shoulders and your hips so that you can run away or you can fight whatever that threat is. But there's only so much blood in the body. So if you're putting more blood into your shoulders and your hips, you're stealing it from those center structures, your brain, your gut, and it can actually affect your digestion and your thinking. So when you're in that fight or flight state, I'm sure, some of us in the room have maybe heard the expression like so scared you peed your pants, right? And the thought with that is the brain couldn't give good blood flow and appropriate stimulation to those center structures, including your bladder. So it had to just void so that it could focus on what it was trying to focus on, which was running away or fighting. So these can very much affect our day-to-day lives. And it's not to say that the sympathetic nervous system is bad. It's really good if there really is a threat in the room. But some people can live in that sympathetic state all the time, and it can be very tiring, and it can make it hard to digest your food, hard to get fuel to your body because you're not digesting well, hard to think clearly or really get good rest. And then on top of those autonomics, we have the second most foundational level of our pyramid, and that's neurological reflexes. So these reflexes allow us to interact with the world around us on a very basic level. So some of the reflexes allow me to keep looking at my camera, even though I'm moving my head because I'm a very animated person. But for some people, that reflex is broken or not working well. So every time they move their head, they lose their gaze fixation, which means they lose their focus from their eyes. We have other reflexes that are neurological reflexes that allow us to, like when we're driving in a car, have all the trees go past us or their cars go past us. And you don't have to spend energy or effort perceiving that. You can just do it automatically. But for some people, that doesn't happen. And they can get motion sickness, or it can be hard to drive, or they can get light sensitivities if the reflex in their pupil doesn't say, hey, eyes, pupils need to close when it's bright out. And then they can dilate when it's dark. For those people that are in that fight or flight state, those pupils can stay big and that reflex doesn't work well. And then they can get very light sensitive. And that can happen with your ears too, or you can get very sound sensitive. And then working our way on up the pyramid. So you need the autonomics and the good blood flow, good fuel delivery, good digestion. Then you need to make sure your reflexes are good. And then for people with developmental delays, we tend to talk about survival reflexes because these are really important in the first year of life. Like when you're an infant, they keep you alive, they help you survive, and then they should be gone by the time you hit 1 year old. So people that have autism spectrum disorder, attention deficit disorder, even dyslexia, can have some of these reflexes that don't ever go away. And it causes that part of the brain to kind of stay immature in a sense. So having the right exercises to get through that and to attenuate or to get rid of those reflexes can be really important. And then on top of that, we have movement, like purposeful movement, like being able to like jump your eyes from word to word to word when you read, or coordinated movement, like being able to run. And then based on all of that, all of those steps of the pyramid, we have behavior. And another way you can think about behavior is cognition in action, right? It's putting your thoughts and expressing them. And usually that expression involves some sort of movement, whether it be nonverbal body language or communicating or acting out or getting in a fight or running away. All of those take movement. So that behavior can be a lot of different things, but it relies on good blood flow, good digestion, neurological reflexes, movement to really be able to have the fullest optimized potential for the behavior. All right, so moving past the pyramid, let's talk a little bit about some of the conditions I see in my practice and how that relates to mental health. So we have brain injuries. It's probably the most common thing that we see, but even it being the most common, it probably only takes up maybe 30 to 40% of our population in terms of the patients at our clinic. You can have a traumatic brain injury, or you hit your head, and it can be mild, which is called a concussion. For people that have a concussion, it won't show up on a brain scan. All their imaging will appear normal. You can also have a moderate traumatic brain injury or a severe traumatic brain injury where there's a loss of consciousness. Maybe there's a brain bleed. So for those people, rehabilitation is needed, but so for concussion as well. Most concussions go away on their own, but 20% don't. And for those people, rehabilitation is really important. But you can also get a brain injury not from hitting your head. You can get it from having a stroke. You can get a brain injury from having a near drowning event. We see this very commonly here in Florida with children. It's the #1 state for it in the US, is near drowning events or non-fatal drownings. You can get it from chemicals, right? So you can almost have like a chemical brain injury from exposure to certain things. We've actually had some patients, I don't know if you've heard the term, but they call it chemo brain. And they feel like their brain function changes after chemotherapy, after having cancer, that they don't think as clearly as they used to. But you can get it from having hypoxic states, which means being low in oxygen. You can get it from seizures or having autoimmune conditions. There are certain autoimmune conditions that can affect the brain as well, certain food sensitivities. Non-celiac gluten sensitivity actually has more neurological symptoms than gastrointestinal symptoms, which can be shocking, but that's, what the research shows is that the nervous system can be affected just as much, if not more so, than the gut in some of those autoimmune conditions that are related to food sensitivity. So lots of different ways that you can have a brain injury. Going from here, what are the common symptoms that we see for brain injuries? Headache, confusion, lightheadedness. So I just want you to kind of take a moment and look at these symptoms that are very common with brain injuries. Some of them maybe make good sense. Headache, light and sound sensitivity, nausea. Some of them maybe about, but maybe it's just not as well recognized. Behavior, mood changes, memory lapses, tiredness. So I want to look at these symptoms with a little bit of a different light, okay? So in highlighted symptoms are symptoms that are probably more likely to be in the realm of psychology than neurology. But ultimately, we're talking about brain health, right? So we're talking about all of it. So these are the common symptoms of brain injuries that maybe could be referred to as more psychological than neurological, but we know that there was a neurological insult that's causing these symptoms. Confusion, difficulty with attention and concentration, irritability, anxiety, memory lapses, trouble with thinking, behavior or mood changes. So let's look to see what the research says. Did you know that 1 in 5 people will develop mental health disorders after a concussion? 20%. 2 out of 10 will develop a mental health condition after a concussion. And for a lot of these people, they say that 80% of people with a concussion get better on their own, but what's going on with those 1 out of 5? They need care, and that's where we have to break down that stigma, and ask for help when we need it, and get rehabilitation and find the right treatment plan that works for you. And after a mild traumatic brain injury, it's estimated that 12 to 44% of people experience some degree of depression in the first 3 months. Some people even develop bipolar symptoms after traumatic brain injury. And for people that have never had a psychological disorder before their injury, there's frequently mental illness after TBI, especially ADHD, personality change, conduct disorder, and then less so, but still there, is PTSD and anxiety disorders. And if you wanted to know more about that, I went ahead and put the links because I want to share science with you. And mental health is science as well, and that brain health. So I really want to be able to give you the resources to look at the research yourselves, not just take my word for it, right? But be able to just do more research and learn more about these connections between neurology, psychology, and what is truly brain health. So let's take another look at those symptoms, right? We have tiredness or sleepiness and a change in sleep habits. These ones worry me. And the reason for that is it can be a very vicious cycle between having an illness that causes sleep challenges or sleep loss, and then sleep loss causing more symptoms that cause more sleep loss. So let's look at the next slide, and we'll be able to really see that something that I found was amazing, but is in the research. In all major neurological and psychological conditions, there can be sleep disruption. All right, to say another way, sleep disruption is present in all major neurological and psychological, aka brain conditions. And the reason I get worked up about this is because sleep loss can cause other symptoms. And now you're kind of chasing, is it the chicken or the egg? Is the sleep loss causing the symptoms, or are the symptoms from the injury? It's all about the brain, right? So if you can make the brain function better, maybe you can sleep better and actually decrease symptoms from multiple different avenues, right? Multiple different approaches. So I just wanted to kind of read off a couple of really interesting facts, at least that I found was interesting, for you too. So there was a study where they took healthy people and deprived them of REM sleep. So these are just healthy, people. They'd never had PTSD before, nothing like that. And they deprived them of their REM sleep, which is the rapid eye movement type of sleep. And after doing that, they actually developed PTSD-like symptoms. So a couple of things you see here, I know this is in medical jargon, but increased autonomic sensitivity to previously extinguished conditioned stimuli. So what that really means is that they were having that fight or flight, that autonomic response, even though that threat was gone. That sensation, that feeling, that response of fight or flight lingered and lasted even after there was nothing to have that response for. The other part is that impaired autonomic discrimination of conditioned stimuli from the safety signals. So what that means is that they were having a harder time understanding or perceiving what the safety signals were. So that's called decreased emotional specificity, but it means that they were having a response to a threat. And because of this lack of REM sleep, they couldn't even figure out what their safety signals were anymore. And you can see how that can ramp you up, right? We know that the brain injury or neurological conditions can cause sleep loss or sleep disruption. And then we know that sleep disruption or sleep loss can cause more neurological and psychological symptoms. So we also know that sleep loss has been found to impair attention, right? And maybe this is one of the reasons why traumatic brain injuries can cause a decrease in attention, is because it's causing a decrease in sleep. And we also know that sleep loss, the sleep disturbances, can affect the ability to filter out distractions, right? It can make it harder to stay focused, to think. And sleep loss can affect learning and working memory. And this can be really intense for children that have a hard time sleeping, and then they have to wake up early and go to school, and then their learning's impaired because they didn't get a good night's rest. Maybe they weren't getting a good night's rest because their thoughts were racing. Maybe they were in pain. Maybe they have autism spectrum disorder and have a hard time with all the touching from the blankets. They have that sensitivity to touch, and it's hard to find a spot where nothing is touching them the wrong way, and they don't sleep well. Maybe they have OCD like tendencies, obsessive compulsive disorder tendencies, where things can't, they can't rest and lay in bed until things are just right. And then they have sleep loss, and the sleep loss causes attention issues, it causes memory issues, it causes learning issues, it causes that increased fight or flight state even when there's no threat in the room. So we're going to move past this and look at one of the things that I talked about just a moment ago, which was autism spectrum disorder, ADHD. So this falls into the realm of developmental delays. This is actually probably the second most common kind of family of conditions that we see at my practice. And as you know, for a lot of these conditions, they're not going to show up on an MRI. They're going to show up because they go to a neuropsych office or a psychiatrist or a psychologist. These are people that some of them respond well to applied behavioral analysis or cognitive behavioral therapy. But something that we have found too, that in conjunction with those therapies, right? And we're not saying we're a standalone functional neurology. We're saying it's always about a group effort, right? It takes a village to raise the kids, so they say. But some of the connections between developmental delays, which are classically considered part of the family of psychological disorders, and how they affect the brain, even if it doesn't show up on a brain scan. So let's see what the research has to say. Cerebellar dysfunction. So I'm going to back up just a second. The cerebellum is a little part of your brain that sits underneath the bigger part of your brain. So cerebellum is actually just Latin for little brain. But it's such a rich area because instead of coming off the hemispheres, the cortex, the big part of the brain, it actually comes off the brainstem as like a little butterfly wing off the back of the brainstem. But that one little area, which is about the size of a fist, actually holds more brain cells or neurons than all the other areas combined. How crazy is that, right? This one little area is so dense and tightly packed with neurons, more so than all the other areas of the brain combined. But that area has been shown that when it's dysfunctional, it's been shown to be dysfunctional in a lot of different developmental disorders, including autism spectrum disorder, attention deficit hyperactivity disorder, developmental dyslexia. And it's also been shown that damage to that area early in development can have long-term effects on movement, sure, but also on cognition, learning, social skills, and mood, right? And that's where we're talking about multiple parts of the pyramid: the movement, the behavior, that whole, middle to top half of that pyramid for neural rehabilitation. Another area to look at is the brainstem. We're going to go back just a little bit longer. But the brainstem has also been shown that to have abnormal development or atypical development in cases with autism spectrum disorder, and that can cause socialization challenges. There's another part of the brain, or really a circuit or a pathway in the brain that works called saccades, or they create fast eye movements, and those have been shown to be irregular with people on the spectrum. And then impulsivity is a common symptom of ADHD, but that can be due to a decrease or lack of inhibition, which is something we'll talk about in a little bit. All right, going to the cerebellum just a little more, because it really is an amazing part of our central nervous system. It's just that little red area right there. Like I said, it's really small, the size of a fist, but it has more brain cells than the rest of the brain combined. Even though the rest of the brain, it looks so much bigger. So speaking of just the cerebellum, there have been research that's found that there are behavioral changes that can occur when you injure that part of your brain, and it can cause impairments in executive function, like planning, set shifting, which is the ability to kind of shut off one thought and then turn on another, which anyone that has had anxiety knows that sometimes it's really hard to shut off your thoughts and then be able to move past it. So we call that set shifting. But the cerebellum has also been shown to have changes in verbal fluency, abstract reasoning, working memory, spatial cognition, like knowing where you're at in space, like, oh, I know that I put my keys to the left of the cup, right? Like spatial memory. And that dysfunction or injury to the cerebellum can cause personality change, blunting of affect, disinhibition, meaning it's harder to filter what to do, what your consequences. And then of course it can create challenges with behavior, right? That it can cause inappropriate behavior if it's injured, or language deficits. So that cerebellum is so rich in function, because it's so rich in neurons. But it means that when that part of your brain gets injured or doesn't develop appropriately, or something happens during development that causes some atypical function, it can show up in the realm of social health, right? With inappropriate behavior. It can show up in the realm of neurological health with working memory and abstract reasoning. It can show up in the realm of psychological health, right? With disinhibition and some of that set shifting and anxiety-like behaviors. So a really, really important part of the brain to look at when you're having social, psychological, or neurological issues. So another subpopulation that we see is neurodegeneration. So this means that part of the brain is degenerating, or kind of like wearing out in a way, or going through changes that creates the tissue to be have less integrity. So some of these conditions can be like mild cognitive impairment, which is something that a lot of us will go through as we age. But other neurodegenerative conditions are Parkinson's disease, multiple sclerosis, Alzheimer's disease, Lewy body dementia, frontotemporal dementia. So as we age, there's a natural amount of degeneration that occurs, but for some people, that amount is pathological. You know, it's much more than is typical. So, you know, a lot of people, they know that they go to a neurologist, you know, when their parents develop Alzheimer's, but I think there's some compelling evidence to suggest that it's not just neurology, right? There's also some psychological effects, some sociological effects, but it's because these conditions affect the brain. So all aspects of brain health can be affected. So let's look at the research on this as well. So I thought this stat, I had to double check it because it really opened my eyes. But did you know that a third of all dementia treatment costs are accounted for by the psychiatric symptoms? You know, it's not the memory, it's the psychiatric conditions, it's the personality changes, it's the increase in aggression or sadness or tearfulness or the ability to process emotions. But a third of all dementia treatment, the costs actually go to psychiatric treatments for the psychiatric symptoms. And the majority of patients with dementia experience one or more disturbances of mood, behavior, perception, and thought content. Cognitive dysfunction has also been observed in cases of remitted, which means it's already gone away. So in cases of major depression and bipolar disorder that's no longer present, but that cognitive dysfunction can stay, can linger, specifically affecting attention, executive function, and memory. And then did you know that depression appears to be associated with an increased risk for late life dementia? That's why it's important, if you have depression, to get treatment for all aspects of brain health. You know, make sure that we're setting ourselves up for success as we age. And then Alzheimer's disease presents a variety of psychiatric symptoms, most commonly apathy, depression, anxiety, irritability, agitation. And Lewy body dementia and Parkinson's disease often experience hallucinations, paranoia, delusions, anxiety, and depression. You know, this one hits my heart deeply because my grandfather passed away from Lewy body dementia. And the kind of the anxiety and the paranoia was real. He had hallucinations. He himself was a doctor. He was a surgeon. and he would relive some of those experiences or see things that weren't there. So this condition, that is neurological, was really affecting his mood, his behavior. And then, of course, it affected his sleep, right? And then who knows how that vicious cycle, how far that went as well. So just understanding that for people that do have neurological or neurodegeneration, that there is both neurological and psychological, and of course the sociological aspects of these diseases, these illnesses. So the next time, we see neuro rehab, I really want us to see brain rehab, right? Because if you're affecting neurology, you're affecting the brain. If you're affecting psychology, you're affecting the brain. And on that same sense, if you're having psychological symptoms, it's from the brain. If you're having neurological symptoms, it's from the brain. So really just breaking down that stigma that there's no relation between psychology and neurology. I mean, that's false. They're treating the same organ. It's the brain. So really looking at like that, like I said, that rehab as it being brain rehabilitation. So I appreciate you guys following along with me this far. I know a lot of you guys are probably thinking, well, what can we do about this, right? Like, oh my gosh, listen to all these facts. It's crazy. What should we do? So let's talk about what we can do about it. So our approach, the functional neurological approach, and we're not the only functional neurologists in the world. You'll actually find functional neurologists in countries, throughout Europe and Australia. They're in Canada. There's functional neurologists all over. We just don't get as much airtime as mainstream, neurosurgeons and whatnot. But the approach for functional neurology is to create or cause neuroplasticity. So that can help increase the nervous system efficiency so that the brain can function better and ultimately lead to a better quality of life. So neuroplasticity is the concept that our connections in the brain change with experiences, right? And we know that that's what happens when we learn. But every time we learn, we have to create new connections, create new synapses. So it's learning, but it's almost like a structured learning. And really, we utilize receptors in the body, which are what we call our senses, right? Vision, hearing, smell, taste, touch. And then we have a vestibular sense that allows us to know where we're at in space. That people don't talk about so often. But we utilize these senses and we stimulate them in specific ways and specific patterns and in specific dosages to affect pathways in the brain to improve the way that different areas of the brain are connected or how they communicate. So the model we have is that every brain is different. So you have to have a patient-specific, customized treatment plan for each patient. So there's no protocols. There's not, an autism spectrum disorder protocol. There's not an Alzheimer's protocol. There's not a concussion protocol. You can't have a protocol when you're working with an organ that is so unique person to person because their experiences have been so unique in their lives and their brain functions based on their experiences. So we make sure that we do multiple hours of diagnostic testing and examination. We end up doing 2 full hours of diagnostics and another full hour of examination and going over history so we can really get that full picture of what's going on in your brain. And then we do that customized treatment plan for a certain number of days. I like the model that's intensive. We do a really intense 5 days, but there's other options as well. And then afterwards, we have an at-home exercise program. And that's because if you're going to make changes in the brain, we're always going to be competing against life, right? We're going to increase certain pathways, and then you're going to go home and do other things. And maybe not all those things that you're going to do is going to be beneficial to your brain, right? So we have these at-home exercise programs to maintain and continue improving brain health. And I really like that because I don't want to make my patients come to see me every day, for weeks and weeks and weeks and weeks on end. I want you guys to be autonomous, right? To feel in charge of your life and know that you have a strategy that if you are feeling symptomatic, whether that symptom is dizziness or anxiety, that you have a strategy and a plan for techniques that you can utilize, exercises that you can do to help improve those symptoms and continue to improving brain health. You know, we say we brush our teeth twice a day. How do the dentists convince us of that, right? Miracle workers. So I'm here to really be a proponent that we should be doing some brain exercises at least twice a day. You know, brush your brain. There's only one of them, and you can't replace it like you can teeth. You know, there's no dentures for your brain. So, and I do my at-home exercises just to keep myself sharp and really continue to improve on my weaknesses. You know, there's a saying that if you have a brain, you can make it work better. Just like if you have a body, you can make it stronger. So that at-home exercise program is really key for autonomy and continued performance. And then our approach is really a multimodal approach. I talk with my patients, other doctors, whether they're psychologists, psychiatrists, physical therapists, occupational therapists, medical neurologists, or just their general practitioner, right? Their family doctor. And that's because we're all on the same team. We're on Team U. And we're all having effects. You know, every medication has side effects and effects. Every exercise has effects. So having everyone that is prescribing either exercises or medications all on the same page can really be helpful to make sure that everyone sees the full picture of what you're going through and what you're doing. So we co-manage with other therapists, and then actually in the office, each session that you have of neurological rehabilitation takes components of different other sciences. So some things we do kind of almost border on the line of physical therapy. Some things that we do border on the line of occupational therapy. And then we combine those in the same treatment. And the thought being that when your brain develops, like as a baby, you don't just use your eyes for 12 weeks, and then you just use your vestibular system for 12 weeks, and you just get language for 12 weeks, and you just get socialization for 12 weeks. Everything happens all at once. So when we're rehabbing the brain, we want to stimulate a lot of different areas in small bits, but over the course of the same hour. So really just trying to get a lot of that activation and connectivity all in that same treatment. So here are some of the treatment options that we have at Plasticity. So these are treatment options that you would find at a functional neurologist's clinic. We have photobiomodulation, which is a crazy big word, but what it actually means is modulating or changing biology, aka the brain, using photons, which is lights. So we have different light therapies that utilizes lasers to increase blood flow, but we'll talk more in depth about each of these here in a moment. So we have non-invasive neuromodulation, which is a specific type of electrical stimulation that doesn't feel like shocking at all. It kind of feels like a tapping. We can do it in various areas. We utilize gaze stability exercises, neuromuscular reeducation, vestibular rehabilitation, go, no-go exercises. And each plan is as unique as the individual. So we have other treatments that we use sometimes and not others, right, depending on the patient. So they can be convergence and divergence exercises. I find this to be really important for people that do have anxiety, because convergence is how well you can perceive and respond to things close to you. So like when you converge with your eyes is when you're looking at a target that's coming towards your nose. And you'll actually find that a lot of people, you know, after a concussion or with anxiety, they don't do a good job with being able to perceive things really close to their face. Sometimes they have a withdrawal response. Sometimes they can make them feel like nauseous or dizzy inside. So convergence and divergence exercises actually utilize the eyes to help rehab the brain. We also do hypnotherapy. So we have a medical hypnotherapist on staff for patients that would benefit from that kind of care. So we also co-manage with therapists and counselors at home. So that really all-encompassing brain health aspect. We also have hyperbaric oxygen therapy, which can be really beneficial for people post-stroke or for those that have traumatic brain injuries. And really what hyperbaric oxygen therapy does is you kind of lay in a tube and it pressurizes air around you, and then we enrich that air with extra oxygen. So this was actually first used in the medical literature for burn victims, but we actually know it just helps healing. So that could be really beneficial for people that have different wounds on the outside, but also different injuries of the brain too. And then we also have neurofeedback. So neurofeedbacks are really cool science where they utilize electroencephalography, which is like a cap on the head that measures the electricity coming out of different points in the head, and then analyzes it for the frequency of the brain activities. These are called your brain waves, and they can actually modify your brain waves to try to regulate them. So we have certain brain waves that are present more often when we're anxious. We have certain brain waves that are more present when we're sleeping. So the thought with this is being able to change some of that electrical activity or the frequency of firing, or change some of those brain waves. And the science shows that it's actually really beneficial for people that do have depression, anxiety. I actually did a really big research study on utilizing a form of neurofeedback with autism spectrum disorder. And at the end of the study, we found that it actually was really helpful in decreasing some of those behavioral outbursts and actually increasing some of the language. Once again, it's all about brain health, right? Not really separating the symptoms that are psychological, neurological. When it's the brain, it's the brain. So let's dive a little more in depth into each one, because I know that not everybody knows what these therapies are. I mean, before I was in this field, I had not heard about this. So photobiomodulation is called low-level laser therapy, or LLT for short. It's that little device that you're seeing on my fun patient there's head, and then we have it in his nose as well. So it improves blood flow to wherever you put it. So we utilize infrared because it penetrates, or it gets through the skull, and then it increases blood flow to the brain. So we can do it on your whole head. It's called transcranial, and that just increases blood flow generally, like for generalized improvement. But we can also be really specific with it. We can do it in your mouth. It's called intraoral. And we can do that because just behind the back of your throat, about 1.5 inches, lives your brain stem. And your brain stem is where your autonomic nervous system lives. So it's where the brake pedal lives for that fight or flight system. It's where the centers live for respiration and heart rate. So we can actually increase blood flow to that region utilizing, so it looks like almost like a flashlight, kind of, with a little like thermometer looking attachment to the back of the mouth, or intraorally. We can also do it intranasally to stimulate the part of the brain that does emotional regulation. It's part of the prefrontal cortex. So as you can see, my little buddy here has it transcranially and then also in his nose, intranasally. And I know he has the biggest smile on his face. But the first time I saw him, he was screaming and crying for 4 days in a row. And on the 4th day, his mom brought him in, and she said, "I don't know what you did, but I got my first moment of peace since he was born." And that's because when he was born, he suffered a brain injury from lack of oxygen due to medical errors. And he was in pain, and his brain wasn't regulating his emotions appropriately. So for years, I think 5 or 6 years, every day he was screaming and crying. And unfortunately, he's not verbal, so he can't always fully express his emotions. Not that any 5 or 6-year-old really can anyways. But nowadays, he is such a happy-go-lucky kid. If you ask him if he wants to be a superhero or supervillain, he still says he wants to be a supervillain. But he's just such a goofball, and you can see from that big smile on your face, he's in a much better place now, psychologically and neurologically. So that device is called a V-Light, or V-Light is what's on his head. And there's different ones that we use for different people. There's an alpha that promotes relaxation. There's a gamma that promotes cognition. But for some people, we'll actually use both in different orders, depending on what they need. So up next, we have electrical stimulation. And this is actually called non-invasive neuromodulation because it modulates the nerves. But it's not invasive. It doesn't hurt. I do it on everything from 18-month-olds to 90-year-olds. I've done it on myself. I've had it done on me. It feels like tapping. So we can do it on different parts of the wrist, the face, the legs. And we do it on the legs a lot to help with walking and gait. But we can also do it on the tongue. And this might sound crazy, but when you look at a lot of the nerves that go to the tongue, they're a part of a system called your parasympathetic nervous system that promotes that rest and digest system. So for a lot of my patients, The first thing we do with every treatment, increase blood flow to the brain, and then ramp up that rest and digest system, right? Because that parasympathetic nervous system, the rest and digest, is what allows good blood flow to the center structures, your brain and your gut. So we also do some gaze stabilization exercises or gaze stability. And the reason we do this is there are certain phenomena that can occur in your eyes where your eyes move even when you're not asking them to. They can have little shakes, like called a square wave jerk. They can have a drifting and a bouncing. It's called an nystagmus. But anytime your eyes aren't stable, it makes focusing on whatever you're trying to do very challenging. I mean, you can imagine that if you were reading and you're looking at a word and then your eyes shake on you just lost your spot, right? You're trying to hold a conversation and maintain eye contact and your eyes go, now you can't maintain eye contact. Your eyes jump to the side. Now you're kind of distracted, So every time your eyes aren't stable, it really opens the door for distractibility. So stabilizing your eyes can help your eyes stay still and focus. Neuromuscular reeducation, when you break down this word, neuro means like the nervous system, muscular, so like the muscles, and then we're re-educating. So we're kind of changing the way the nerves are and how they communicate with the muscles, which can help with coordination. It can help with tone for people that are hypotonic or hypertonic or have spasticity of their other muscles. And it can also help with spatial orientation. But these types of exercises can activate the cerebellum. And we learned just a little bit ago that cerebellum, when it's dysfunctional, it can cause memory issues, learning issues, attention issues, behavioral issues, right? And movement issues. So I like to refer to the cerebellum as the great balancer. It balances our movements and it balances our emotions. So one way that you might think of it at home is that if you've ever seen someone, right, like whether it's you or someone else that has drank alcohol and gotten drunk, because of how rich in neurons the cerebellum is, the cerebellum gets affected very quickly with alcohol intake. So when you think of the cerebellum, one of the ways it can get weakened is when you're drunk. So when you think of what does a cerebellum do when it's not working right, well, what does a drunk person do? All right, do they have good emotional balance? Probably not. Maybe they have slurred speech. Maybe they have a hard time walking. Their movements aren't accurate. Their emotions might not be appropriate. So the cerebellum, if you can exercise it, you can actually get improvement in the balance of your emotions, improvement in the balance of your movements. So having neuromuscular reeducation can be really beneficial, especially in the conditions that we know can have dysfunction of the cerebellum, like developmental disorders. And then we have go, no-go exercises. So these help inhibition. And inhibition is the ability to not do something, which might sound easy on the face of it, but if you've ever met a kid, don't hit that red button is really hard for them to do. So we have a machine here we have a little girl at it in the photo. So we're telling her, hit the red, not the green. And the next time she comes in, we might say, hit the green, not the red. And she has to respond to our directions. And that helps with that inhibition. And then we do it in a way that's fun. So she's getting dopamine, which is one of the neurotransmitters that makes you want to do things, right? So improving inhibition through exercises called no-go exercises or go-no-go exercises. And that also helps develop executive function as well, which can be really important for people that have cognitive affect disorders, developmental delays, and many other conditions. And then this is the last therapy I'll talk about with you guys, but it's called vestibular rehabilitation. So this one on the face of it probably looks a little wild, but I promise you that she's not hanging upside down. We're actually in the process of spinning her in a full circle, like she's doing a cartwheel. So vestibular rehabilitation helps the vestibular system. And this is the system that perceives gravity and movement. So when you do vestibular rehab, it can actually help with the perception of movement, with balance, with spatial orientation. But a different reason we might want to do vestibular rehabilitation is because the vestibular system has connections with the autonomic nervous system, which is that fight or flight or rest and digest system. So let's go ahead and look a little bit more into these different vestibular connections. So a little more research thrown at you, but damage to that system, the vestibular system, actually leads to deficit in spatial navigation, which can affect memory and learning with spatial implications. Vestibular disorders can exhibit cognitive deficiencies, memory deficiencies, and then vestibular dysfunction has been shown to affect attention. And then MRI shows that when you have bilateral or both sides of the vestibular system damaged, that your hippocampus, which is actually a part of your brain a little further away from your vestibular system that helps with long-term memory, that can actually atrophy or shrink. So that vestibular system can affect learning and memory and attention. But did you know that people with vestibular deficits experience a very high incidence of depression and anxiety disorders? So this is just another link, right? Connecting those dots between what we would consider neuro rehab and how it can just help the brain and all of the functions of the brain, including neurological functions, psychological function, and sociological functions. So I wanted to share with you a couple of my patients, and I changed their name. We're going to call this one John. That's not his name. But he came in, and this guy really stuck out to me. I don't know. Do you ever just have one of those patients or one of those people in your lives where the moment I heard his story, I was like, I want to help you. Anything that I can do, like, let me know. So John, he came in, and I was reading through his intakes, which is like his medical history on the first day. And I do this before I see all my patients so that I know what questions I want to ask them. And that way I have the background of what they've gone through, and then I can be there for them as they kind of share their history with me. And we ask our patients, what is your primary goal of seeking care at Plasticity? And he wrote down, I just want to stop trying to kill myself. And it just hit me, that like, I need to help this person. Whatever we can do to get his brain to function better, like, let's do it, right? So his history, he had depression, he had anxiety, he had previous suicide attempts. And then once I really started talking to him and figuring out, what could be going on in the brain that's causing all this. He also had multiple undiagnosed head injuries from sports when he was back in high school, and then from fights. He was someone that got into bar fights fairly frequently. So undiagnosed, but suspected concussions, and then a history of mental health disorders as well. So, what did we do? The treatments that we gave, we did it over 5 days. For the 5 days, the first day is our intake day. So we do that 2 hours of diagnostics, an hour of an exam, and then another hour of treatment. And in that treatment, we kind of discover, I know what I want to do with each person, but how much can they tolerate? So that's where I can really customize it even more to exactly what they can handle, what they need, how I can push them. And then on day 2, we do all treatments. So it's 3 treatments that day. On day 3, we do a little mini check-in, exam and diagnostics, and then 2 more treatments. On day 4, we do 3 treatments again. We take breaks between each treatment, make sure they can recover, get time to rest, get food. And then the last day is exit day. So we do the 2 hours of diagnostic, hour of exam, and then 1 more treatment. And in that treatment, we teach them their at-home exercises as well. So we had those 5 days. We did hypnotherapy for 3 days in a row. We did photobiomodulation, increase blood flow to his brain. We did electrical stimulation to increase activity in that parasympathetic nervous system. And then I did some on his body as well. We did gaze stability exercises because when he came in, his eyes were drifting and jumping and drifting and jumping. It's called that nystagmus. We did vestibular rehabilitation, neuromuscular reeducation, go, no-go exercises, and then cognitive exercises to help with his memory and spatial orientation as well. So we saw that he had improvement in processing speed. We saw that he had improvement in inhibition, the ability not to do something, which was really important, right? If your main goal is to decrease some of those suicidal ideations, right? The ability not to do whatever you're thinking of. But we also saw improved symmetry in his autonomic nervous system. And that he overall just had less sympathetic tone, which means he was a little more in that rest and digest state than that fight or flight. And then his symptoms, he came in, he said they were about a 24, with the higher score being the worst score. And then we dropped him down to an 11 when he left. So he was feeling really good when he left. He was a little tired from the week of therapy, but he performed really well and he was really hopeful. And he actually said he'd called some of his friends up and they had mentioned like, hey man, like your voice sounds different. Like I feel like I haven't actually talked to the real you in years and you sound like yourself again. So that was really cool that we had, you know, people that didn't even know he was getting treatment kind of mentioned like something's different about you. Like you seem more alive. So you know, one of those patients that just stuck with me. I just wanted to share his story with you. And then one more patient. We'll call this one James, even though that's not his name. But he came in, he had no official diagnosis. He's like, hey doc, I don't have anything wrong with me. I haven't been diagnosed with anything, but something is not right. I do not feel right. I don't feel good. I can't keep living like this. Like, please help. And then we started talking, and he had a history of he had a car accident, you know, a few years ago. He had some falls, but nothing was diagnosed. Nothing required surgery. So some suspected concussions. But we asked him to grade his symptoms, you know, 0 to 6, 0 being no symptom, 1 or 2 being mild, 3 or 4 being moderate, 5 being severe, and then 6 being the most severe, right? And when we looked at the symptoms that were psychological, you know, before we did the treatment, and then we asked him to grade him again at the end of the 5 days, here were some of the symptoms that he had commented on. More emotional. He said that was severe. He said 6 out of 6. When he left, mild, 1 out of 6. Sadness went from a 5 out of 6, which was severe, down to a 0, not even present anymore. We had nervous or anxious going from a 5, which is severe, down to a 2, which is mild. We had irritability going from a 6, which is severe, down to 2, mild. Then we had this kind of feeling of, I just don't feel right. Like I just don't feel like myself. I just don't feel right. And that was severe as well, 6 out of 6. And then when he left, he said it was all the way down to a 2 out of 6. He said it was mild. But when he came in, his symptoms were 111, which puts him in the category of severe. He is not feeling good at all. When he left, he had over a 60% improvement. He went all the way down to a 46. So if you're looking at the little graph on this screen, you'll see the very bottom says 50th percentile norm. So this is what they deemed was normal after testing 10,000 people. Then you'll see the baseline for July 29th, which is when he came in. And then the top row is when he left, which was August 2nd. So just 5 days. So his symptoms went from 111 down to a 46. His Trails A time improved. So let me just give you a little history. The Trails making test, they call it Trails A and Trails B, was a test that they used to give soldiers back in the World War for shell shock. Well, we know shell shock's not an official diagnosis anymore. Shell shock is usually a traumatic brain injury from a blast injury mixed with PTSD, post-traumatic stress disorder. So this is a test that we kind of adopted from the past. And we say Trails A is connecting the dots 1 through 25. Just, 1, 2, 3, 4, 5, all up to 25. And it took him over a minute when he came in, and we got that down to 41 seconds. And then Trails B is a set shifting task. And if you remember, the people that have a hard time with set shifting are people that have anxiety or OCD-like tendencies, because this is the ability to shut off one train of thought and jump to a different train of thought and go back and forth using mental agility and cognitive flexibility. So this test, what it looks like is connecting the dots but you're going 1A, 2B, 3C, 4D, 5E, all the way until you hit 13, which ends up being 25 dots. So he couldn't even do that when he came in. He tried, and we give everyone 3 chances. So it's not like he had just a bad run. He tried and he tried and he tried, and he could not get it done. He could not switch off those thoughts and switch between those 2 trains of thoughts fluidly or fast enough. When he left, he was able to do it. He was actually able to do it in 84 seconds. So really proud of him for being able to complete that task. His processing speed went up. This is how quickly you can think. We test this by digit symbol matching, but it went from a 35 up to a 41, which was good because it's scoring how many he got correct in 2 minutes. So he got 41 when he left, which was 6 more than he got when he came in. And then we also look at reaction time. So we have simple reaction time, which is just hit the green dot when it shows up. And he actually improved by over 100 milliseconds. So a really big improvement there. He went from below average to above average, so better than average with that. And then we had choice reaction time. So this one, we have 2 dots pop up on the screen. One's blue, one's green. And we say, choose the green, not the blue. And when he came in, it took him almost 750 milliseconds, 3/4 of a second, to be able to hit the green one. You know, that's dangerous when you're in a car because you have to know when to brake, when to gas. But when he left, he shaved almost 300 milliseconds off of his time. So all the way down to 450 milliseconds. So I know some of the cognitive aspects, may be applicable, maybe not. But I wanted to go back to those symptoms because 111 down to 46 is an astronomical change in his quality of life. So we'll go to the next slide and you'll actually see his symptoms on intake over on the side there. And look at all the red, look at all the orange, so much red. And then you want to know what you see at exit? No red. He did not mark a single symptom as severe. And he had marked, I want to say like 10 or 15 symptoms as severe when he came in. And some of those were psychological, right? With the sadness, with the irritability, with the anxiety. And some of those were neurological, right? Balance problems, sensitivity to light, sensitivity to noise, looking at difficulty sleeping soundly, ringing in his ears. But really what you're looking at is someone's brain health before treatment and then their brain health after treatment. Right? And I think you can really see that difference. So what it comes down to is that when your brain functions better, you can feel better. So I just wanted to say thank you. I appreciate your time. I appreciate you, tuning in on a Monday night before American Thanksgiving. And really thank you for wanting to just learn more about why mental health is brain health and why I really do feel that we need to break down that stigma, break down that wall between these 2 fields and really start seeing that these psychological aspects, they're from the brain. These neurological aspects are from the brain. And wanted to share with you how maybe brain rehabilitation is what's been missing from your treatment plan. So thank you so much. I appreciate your time.
Right. Well, thank you, Dr. Kalambaheti. We so appreciate your time here. And at this point, we will take a break and pause for questions. So if anyone has any questions, feel free to write them down in the chat or feel free to unmute yourself at this time to ask those questions.